Okay, sir. So just next 5 minutes, then we'll start, sir.
Okay.
Thank you, sir. Thank you. Hello. Yeah, technical team, rhythm team. If you can just make Tushar co-host, that he can share the presentation. Sorry, are you sharing your screen? I think I can see the screen.
I think I will share. No problem.
Okay, okay. No issue, sir. Perfect. So I can see the slide, sir. It is visible, sir. Yeah. Hello. Yes, sir. Good evening, sir. I think remaining panelists have also joined, sir. We can start with the meeting, and I think one or two expert panelists are yet to join, so they will be joining in next 5 minutes. So we can start, sir.
Okay, no problem.
Okay, sir. Thank you so much, sir. Good evening to all of you. I'm Lekpal Shrivastava, working as an RBM for this division for Cipla Heart Failure team. So I would like to welcome all of you for this scientific meeting, expert panelist meeting, basically for the role of MRA in the management of heart failure, expert talk. And before I would start, I would like to just welcome the moderator as well as the expert panelist on board for the today's scientific discussion. I'm very excited to have the esteemed and panelists on board. First of all, I would like to welcome Dr. Pankaj Harkut. Dr. Pankaj is DM intervention cardiologist, and currently he is intervention cardiologist at Swastham Super Specialty Hospital, Nagpur, and he is visiting cardiologist to Sant Achyut Maharaja Heart Hospital, Amravati. And Dr. Pankaj has been offering his field of specialty, that is into cardiology, since almost more than 2 decades. His services for Nagpur, and basically he has done thousands of individual angioplasties and procedures, and his interest lies in PCI, clinical cardiology, cardiac critical care, atrial fibrillations, and radial route interventions. And Dr. Pankaj has multiple publications in the national and international journals. And so with this, I'm very excited to have Dr. Pankaj on board. He'll be sharing his expertise and moderating the entire panelist for the role of MRA in the management of heart failure. So welcome, Dr. Pankaj. Apart from this, thank you so much, sir. I'm very excited to welcome the rest of the expert panelists for today's meeting. So I would like to start with Dr. Arjun Deshmukh. He is a consultant intervention and intensivist and diabetologist at Sunflower Hospital, Nagpur. Dr. Sudhir Bhatnagar, consultant physician practicing cardiologist, Abhinav Hospital, Nagpur. Dr. Tushar Kapse, consultant physician, Nirmala Tai Kapse Clinic, Diabetes Thyroid Care Center, Nagpur. Dr. Hassanul Banna is a consultant physician practicing diabetologist, Nusra Diabetes Center, Nagpur. Dr. Bharat Rathore, Consultant Physician, AIMS Hospital, Nagpur. Dr. Amol Dubey, Consultant Physician, AIMS Hospital, Nagpur. Dr. Gaurav Subedar, Consultant Physician and Practicing Diabetologist, Subedar Clinic, Nagpur. And Dr. Harish Chaudhary, Consultant Physician, Arneja Heart Multi-Speciality Hospital, Nagpur. So, with this, I would like to hand over the session to Dr. Pankaj, and over to you, sir. Thank you so much, sir.
Thank you very much. So basically, heart failure, as all of us know, is a disease of elderly population, which and with increasing comorbidities day to day, the problem of heart failure is growing. But what we see in heart failure management is that the newer drugs are coming, and the few of the older drugs are being recommended. Currently, one of which is mineralocorticoid receptor antagonists. These drugs have reinvented themselves and become one of the pillar in management of heart failure nowadays. So let's review this drug in detail today in heart failure management. And I'll be sharing the slide, but I think this whole expert opinion forum, I will encourage you to interrupt me. I'll encourage you to give your opinion openly, and this is open forum for discussion, so that each one of us will gain insight into the clinical management of patients with heart failure.
Sir, I would like to just interrupt, sir. If you can just convert this slide into slideshow, sir. This screen.
I think it is in slideshow mode only. It is in slideshow mode only on my side.
Okay, okay. No
Are
issues.
you able to see it in slideshow mode?
No, sir. It is showing that all the slides are also visible, and the screen is PPT is visible separately. That entire slideshow mode is not. I think, sir, you'll have to close it, which is featuring here. If you can just close it.
This one?
No, no, sir, no. At the bottom of the left side of the bottom, so there is. If you can close it, then I think probably that it will start featuring into slideshow mode. Bottom left, bottom, sir. When close. Yeah. Okay. Okay, sir. It's fine. I think it's readable. No issues. No issues. Yes, sir.
So basically, objective of this forum is to have where is the place of MRA in heart failure management. And as all of us know that hyperkalemia is one of the most important problem when we initiate the treatment with MRA. So how much is that concern, and are we justified in withholding MRA in few of our patients with the concerns of hyperkalemia? So these are the basic objective of today's. Coming to heart failure epidemiology, all of us know that almost 1% of our total population, whether it is India or globally, is suffering from heart failure, and more larger population is either having risk factors for heart failure. So, and with increasing comorbidities like diabetes, hypertension, CKD, the prevalence of heart failure is definitely going to be increased. Again, with increasing longevity, as the age advances, the stiffness of heart increases, and thereby contributing into the heart failure. So we know that this problem is going to increase, prevalence is going to rise, and the mortality, again, as the prevalence increases, the mortality will also be increasing. But good news is that now with newer molecules, newer treatment modalities, newer interventions, we can very well stabilize this patient. So coming to first question, which we want to discuss today, is what percentage of heart failure patient approach to you in NYHA stage 2, 3, and 4, and how many heart failure patient goes undiagnosed in India at early stage, and why? Anyone from expert panel will like to comment on this? And what are the diagnostic and prognostic tool used by you in heart failure patient? These are the two questions which we will be discussing initially.
Good evening. Am I audible?
Yes, yes.
Yeah. Firstly, I'll first come to the second question. What are the diagnostic and prognostic tools? First, initially, we should start with the clinical examination of the patient. We should ask the history of the patient first. What symptoms does the patient come to in the OPD or in the casualty? So we should first ask what symptoms does he have. We should correlate it with the heart failure symptoms, and then secondly, after once we know what the complaints the patient has, then we should next would be the clinical examination. We should first focus on the symptoms and the signs, whether the patient has cough, breathlessness, swelling over the legs. These are the more common symptoms, and then we should come to these signs: raised JVP, edema feet, basal crackles. So firstly would be the clinical scenario of the patient, clinical examination of the patient, and then the diagnostic tools would be firstly the laboratory tools and the non-laboratory tools. So if we talk about the non-laboratory tools, it would be basic. Firstly, ECG, chest X-ray, 2D echo. Most important in today's practice is 2D echo. So these are the mostly non-laboratory, more commonly used tools for the diagnosis and the diagnosis of heart failure. And in the second, the laboratory parameters, as we all know, N-terminal proBNP. This is a this has a very clinical relevance, especially in heart failure patients, barring a few exceptions, especially in patients who are in renal failure. If they higher the BNP, then we can correlate with the clinical picture that patient is in heart failure. And when it comes to the percentage of patients, stage 2, stage 3 percentage patient, I would say somewhere between 30 to 40% patients come to the hospital with stage 2, stage 3 NYHA. And stage 4 would be slightly a bit less, around 10% patients. And these heart failure cases could get, they couldn't get diagnosed mostly at the rural level or the primary level. Or suppose if a patient goes to the family doctor with say symptoms of cough, breathlessness, the family doctor might feel he has just upper respiratory tract infection or any other viral fever without examining him properly or without doing the investigation part. So this is also one of the reasons why the diagnosis of heart failure is missed.
Rightly said, Miss. As far as diagnosis part goes, they goes underdiagnosed because of the lack of awareness that this can be heart failure. Many of the heart failure patient or breathlessness patients are wrongly diagnosed as asthma or respiratory issues, as rightly pointed out by you. If we go by basic diagnostic tool, ECG and echo, will you like to elaborate more? Which are the findings which you see in ECG?
ECG, firstly, we should focus on the left ventricular hypertrophy part. And that indicates the patient is having a structural heart disease. So once a patient has left ventricular hypertrophy, then these patients have we are sure that he has some structural heart disease. So they are prone to heart failure. So left ventricular hypertrophy we should see in patient in ECG, in especially heart failure patients. And for echo, left ventricular end diastolic volume, left ventricular hypertrophy, inferior vena cava dimensions. So these are the parameters which we routinely see in echo in patients with heart failure.
Yes. So ECG basically you will see for chamber hypertrophy. Then QRS duration is one of the most important
Yes.
factor which you should see in ECG. Whether there is a QRS duration. So if it is wide or not. Then rhythm part also you should look, because atrial fibrillation is the commonest arrhythmia which is associated with heart failure patient. It might reduce the cardiac output whenever there is onset of atrial fibrillation in patient with heart failure. So rhythm, again, QRS duration, chamber hypertrophy. These are the few things which we should concentrate while looking at ECG of patients with heart failure. And if there are any Q waves suggesting a previous myocardial infarction, so all these things are important. And then as far as echo is concerned, one of the most important diagnostic tool in heart failure. So basically that determines whether it is a heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. So ejection fraction is the one most important key parameter which we look in 2D echocardiography. Then echocardiography, as rightly pointed out by you, diastolic function, chamber hypertrophy, and valvular heart disease. What is lies means IVC, congestive status. All these can be assessed by 2D echocardiography objectively. But most important parameter which we will be seeing is ejection fraction, because that will totally differentiate patients management, because patients with preserved ejection fraction needs a different set of management, and routinely they don't means they only respond to diuretic. They don't need elaborate treatment as required in patients with reduced ejection fraction. So coming to our next slide, what are the which caution we should exercise while using MRA in patients is one is serum potassium level. It should be more than caution is whenever patient is having serum potassium more than 5, you should not initiate mineralocorticoid receptor antagonist. And severe renal impairment is another caution where you should be very cautious in starting MRA. That is if GFR is less than 30 or if creatinine is more than 2.5. These are the two subsets of patient where you should be very critical and thoughtful in starting patients on MRA. So coming to next topic of discussion, what are these parameters, that is potassium level, creatinine, to be tested before, and when you should initiate MRA, and how long it should be continued and how long it should be monitored. This is another question.
Good evening, sir. Myself, Dr. Rathod. Am I audible?
Yes, you are audible.
So, in our setup, sir, usually we start MRAs in patients with heart failure with reduced ejection fraction coming in NYHA class 2 or 4 symptomatic patients, and provided they have eGFR more than or equal to 30 ml per minute per 1.73 meter square body surface area, and their serum potassium should be less than 5 milliequivalent per liter. To protect creatinine monitoring before starting this, then we repeat it after 1 week, then 4 weeks, and every 6 months. And this is for initiation as well as whenever we intensify our therapy of MRAs, we do same 1 week, 4 week, and every 6 months.
Are you more means in case patient is having borderline creatinine?
Yes, sir. Yes, sir. In cases of clinical instability, we do it more frequently.
Yes.
Yes.
So basically, when patient is fluid overloaded in a heart failure patient, you do these things. But when patient is fluid depleted, or if patient is having any episode of diarrhea, vomiting, or where there is fluid loss, and you feel these patients are prone for hyperkalemia, you do it more frequently. So
Yes.
as and when clinical requirement is there, you monitor this potassium level, creatinine level. Otherwise, in routine management, as you rightly pointed out by you, you do it periodically. So in patients who are, you think the means hyperkalemia prone patients, you frequently monitor the potassium level. In otherwise, you do it routinely.
Yes, sir.
Yeah, Dr. Bhatnagar.
Yes, sir.
Good evening. Yeah, I check the blood pressure. So which pillar should use? ARB, ARNI, or MRI? The blood pressure should be the criteria. If blood pressure is low, then RD cannot be given below 90 like that.
Yes, sir.
And ARB is also be restricted. We should start with the MRA. The pressure should be fine. If the pressure is 140, 80, 140, 90, then first drug will be the diuretic plus ARBs. The second, what is the line of treatment of starting? You should not start the 4 drugs just tentatively. By step, you should go. Generally, we do like that. So, what is your opinion? Like
Yeah.
so, BP criteria.
Sir, basically, whenever patient of heart failure is there and patient is fluid overloaded, so definitely there is a role of loop diuretic that you will start.
Yeah.
Then secondly, whenever BP criteria, as far as MRA is concerned, BP criteria is not there.
Not
So
there.
you will start MRA. As far as beta blockers and ACE inhibitors or ARBs or ARNIs are concerned, you will have to look for BP parameters. So in that also, if as rightly pointed out, if patient's systolic blood pressure is there, you can start with means initially beta blockers and then ACE inhibitors or ARB and ARNI.
Yeah. Okay.
Because if you are already started with MRA, then you wait for starting ACE inhibitor. Better will be to start with beta blocker. Again, there will be if there is a tachycardia and all those things. So basically, in which is to be started first in all these these are the initial 3 pillars: MRA, ACE inhibitors, ARBs or ARNI. This is a second pillar, and third pillar is beta blocker. Fourth pillar, which we are nowadays adding, is SGLT
inhibitors.
So these are the 4 pillars which any heart failure patient should be started. Of these, MRA are means they are BP neutral. You need not think of blood pressure when you are starting BP. MRA. Just think of potassium and creatinine and fluid status. Fluid status is very important because if patient is fluid depleted, then if starting initial dose of MRA will suddenly rise the potassium level. So if patient is very fluid overloaded, then you can start with diuretic, and simultaneously to counter the hypokalemia effect of loop diuretic, you should always start with MRA. And then you can initiate with depending on beta blockers or ACE inhibitors. Means, there is no particular choice whether ACE inhibitor should be it or whether beta blocker should be it.
Individualized therapy should be given. Yes, individualized.
And if patient is ischemia or if patient is tachycardic, means if you feel that patient is post-MI patient is having ischemic heart disease, then definitely beta blocker should precede the ACE inhibitor or ARBs. Otherwise, you can start with ACE inhibitors also.
Sir, hello. Sir, sorry for interrupting in between, sir. I would like to, sir, just request all the panelists if you can just switch on their cameras, sir. It will be more interactive, I guess, sir.
Yes,
yes. This is just a request, sir. Yeah. Thank you. And sir, slides were not moving. I think whether you are changing the slide, it was not moving, sir. I can see only HF Global Epidemiology, sir. Yeah.
But my side it is moving. I think you can start sharing from your side. There is no issue. You can start sharing.
Okay. Now it's moving. Now moving, sir. Now it's moving. Yes, sir.
So basically, heart failure guideline recommendation for MRA is that it is a class 1 recommendation for heart failure with reduced ejection fraction, and there is no doubt about it. It is one of the most important pillar in heart failure treatment, and GDMT also recommends that it should be started as early as possible in heart failure treatment. When heart failure with mildly reduced ejection fraction may be considered to reduce the risk of heart failure, where it is class 2B. So patient with preserved ejection fraction, MRA may not be that effective, where loop diuretics will be more effective for symptomatic relief. But in patients of reduced ejection fraction, there is no doubt that these patients class 1 indication is MRA, and irrespective of whatever drug background therapy is going on, you should always consider MRA is one line of treatment which should be initiated in these patients. So this is an overview which we were talking management of heart failure with reduced ejection fraction. To reduce mortality, all patients should be on ACE inhibitors or ARNI, then beta blockers, MRA, and SGLT2 inhibitor. As far as I want to know the comment on ACE inhibitors versus ARNI. Is there any choice in which patient you prefer ACE inhibitor and in which patient you prefer ARNI? Any comment from panel? ACE inhibitor versus ARNI?
The PNB is maybe criteria. If it is high, then RNA will be choice. BNP. Yeah?
Yes.
If it has been done, yeah, it's available. It's available. And post MI.
Yes, sir.
Post MI patient, the ACE inhibitor first choice. Post MI heart failure. These two I know. And what other?
LV dysfunction is mild, then you should start with ACE inhibitor rather than ARNI.
Yeah.
If LV dysfunction is severe, you should straightway think of ARNI rather than ACE inhibitor.
Yeah.
So echocardiography will guide you in whether you should start with ACE inhibitor or ARNI.
Okay.
And if patient is then reduce heart failure, hospitalization, and mortality. So basically, morbidity reduction, heart failure reduction. Patient, if it is volume overload, you should think of diuretics.
Yes.
And so this is a diuretic is basically a loop diuretic where you should think when patient is volume overloaded. Then you should go for ECG if LVBB and QRS duration more than 150 millisecond. Then CRT will give optimum means one of the treatment modality which is available. But here also you should first patient should be stabilized on medical management, and if in spite of your medical management patient continues to be in class 3, class 4, and if there is a recurrent hospitalization, then only you are justified in putting a costly devices like CRT or CRTD. ICD, if there is a ischemic etiology and LV ejection fraction less than 35%, then ICD is indicated to prevent the arrhythmic deaths. Then if there is a atrial fibrillation, you should start with oral anticoagulation. Atrial fibrillation, digoxin can be thought of if there is a regular treatment is failed to achieve the rate control, then digoxin. But nowadays there is no proper for digoxin, at least in a routine heart failure management, there is no role of digoxin. Only if in case of atrial fibrillation, if by routine beta blockers and other drugs, if rate is not controlled, then you can think of digoxin. So digoxin nowadays, we don't see any prescription of digoxin nowadays in routine heart failure treatment. And if there is a structural heart disease like aortic stenosis, you should consider it for surgical aortic valve replacement or TAVI. Mitral regurgitation, then you have to see what is the cause of mitral regurgitation. If there is an untreated valvular problem in this patient, then you should always think for valve replacement or valve repair. If in spite of adequate beta blocker, the heart rate is more than 70, then we can think of ivabradine in this patient because as per SWIFT trial, we know that it reduces the repeat hospitalization and also helps in management of this patient. Then hydralazine is one drug which I mostly use in heart failure patients where blood pressure is not controlled, like CKD patient. Hydralazine can be utilized. Then ARB can be used when there is a ACE inhibitor or ARNI intolerance. ARBs can definitely be thought of. So this is a guideline directed medical treatment for patients with heart failure. Is anything, any comment from panelists in all this management?
Your take on use of ARV or ARNI in CKD patients who are on dialysis for in heart failure patient, basically LV less than 35 with hypertensive response.
Sir, we in patient who are already on dialysis, we can use these drugs, but patient who are not on dialysis, there is no rationale in using these drugs. The chances of hyperkalemia and all those will be higher. So it is not recommended patient who are not on dialysis, but patient who are on dialysis and in spite of that patient continues to have class 3, class 4 symptoms, definitely these can be tried. And the chances of hyperkalemia and other complication will be less if patient is already on dialysis. But again, this is an off-label indication. It is not indicated as per guideline in this patient. Arjun, do you want to comment?
Sir, wanted to ask in patients with heart failure with atrial fibrillation, we have discussed about digoxin. So, does it have any mortality benefit?
No, digoxin, clearly there is no mortality benefit, only in some patients with atrial fibrillation where you cannot control rate with routine drugs. It can have some symptomatic benefit, but it does not have any mortality benefit. In fact, with digoxin, what I perceive is that the mortality may be higher because it's also a pro-arrhythmic drugs. With hypokalemia happening so frequently with use of diuretic in heart failure patients. So management of digoxin is very tricky, and we have seen many patients developing digoxin toxicity because of electrolytes going haywire in patients with heart failure on diuretic. So in routine recent management of heart failure, digoxin has got no role. I am totally against use of digoxin in heart failure patient as a routine treatment. Only in disparate cases you may think of digoxin.
We will be considering starting MRA on day 1 of discharge once patient is discharged from acute LVF.
So MRA, I think you should start with the first dose of diuretic. You should not wait for MRA to be start on the time of discharge. You should start when patient is hospitalized, because that is a time when you will be frequently monitoring potassium level and creatinine level. So as soon as creatinine and potassium level is available in patients with heart failure, you should think of MRA.
Is Finerenone is available in India? Finerenone, the newer non-steroidal MRA. Is it available? Finerenone.
I am not aware, sir. I am not aware.
It's newer drug.
It is going to be launched next month. One of the colleagues had come. Maybe next month it is being launched in Nagpur.
Yeah.
Okay. It's very good drug. Yeah. Because of side effect of steroidal MRAs is non-steroidal.
And hyperkalemia tendency is less with this drug.
That's yeah. Okay.
It would be coming in 10 mg or 20 mg, the tablet.
So coming to next question, in what percentage of patient do you use MRA for heart failure management? And when do you consider starting MRA in patient with heart failure along with ACE inhibitor, ARB or beta blocker? So this is what actually we have discussed. Any comment from expert panelists?
We are the physician. We don't expect much heart failure patient. But in my routine practice, around 1 or 2 patients per day out of 60 patients, they are the heart failure patients. Yeah. And older hypertension patients, they are recently diagnosed as a heart failure. Yeah. In the cardiology practice, the heart failure patient percentage may be more. Yeah, 30%.
Yes, sir.
Yeah.
Nowadays, we are getting almost 50% of our patients comes with heart failure or
yeah.
So that is, and what percentage of these heart failure patient do you use MRA?
Probably
Sir,
nearly.
we usually aim to start it in all patients unless it is contraindicated. So EGFR less than 30 and hyperkalemia. These are only contraindication from our side, and remaining all the patient we try to start in on day 3.
Yes. So this is a basic crux of all this our discussion panel. So all patients of heart failure should be on MRA if there is no contraindication. So this is a statement which we want to make out of this consensus meeting, that all patients should be on heart failure patients should be on MRA. And when do you consider starting MRA in patients with heart failure along with ACE inhibitor or ARB and beta blocker? So I think my practice is that ACE inhibitor, ARB and beta blocker, even before that I will like to start this patient on MRA. As soon as I give loop diuretic, and if potassium and creatinine report is available, I will start them on MRA.
There is definitely better mortality morbidity benefit with MRA if we start at an earlier stage.
Earlier stage.
Yeah.
So that is that has been shown in various trials. We'll be coming to that slide also. So there is another phenomena in congestive heart failure, that is aldosterone escape phenomenon. So that is basically you should start this ACE inhibitor ARB along with aldosterone to prevent this aldosterone escape phenomenon. What happens whenever we start this patient on ACE inhibitor, the aldosterone level goes up, and aldosterone level, whenever aldosterone level goes up, it increases the angiotensin 2, and angiotensin 2 is a potent vasoconstrictor. So we do not want that this aldosterone level should go, and that's why whenever we start this patient on ACE inhibitor, we should start with aldosterone to prevent this escape phenomenon. It is not that after starting this aldosterone MRAs that aldosterone escape phenomena will not happen. It might happen, but the chances will be lesser. And what we know about ACE inhibitor resistance, so as the mortality benefit, as we continue ACE inhibitor in patient with heart failure, it goes down. Why? Because of this ACE inhibitor resistance phenomena. So this aldosterone level keeps on increasing in spite of ACE inhibitor on board, and this can be prevented with early use of this MRS. So this is a slide I think we'll first go to. When do you prefer using eplerenone and spironolactone? So what are the patient profile in which you will prefer eplerenone, and what are the specific patient where you will be using spironolactone? Dr. Rathod, any comment?
Sir, we usually use spironolactone in our setting. If patient develop side effects such as gynecomastia, in females PV bleed, then we switch over to eplerenone. Though spironolactone is potent, being a non-selective MRA, it has got this side effect. And majority of patients, they are poor. So I think cost-wise, spironolactone will be economical in such patients. So in our setup, practice is to go with spironolactone.
Yeah, rightly said by you. So basically, spironolactone is a non-selective receptor antagonist. So basically, all these androgenic and progestin hormone side effects will be more with spironolactone than eplerenone. So if patient develops gynecomastia or other side effects, then we can think of eplerenone in place of spironolactone. Second thing which I see in practical clinical practice is that the combination of diuretic with loop diuretic, spironolactone is easily available. With eplerenone, we have 2 tablet pills, means they are not basically a combination drugs is not available with eplerenone. They come with combi pills, but in one tablet it is not available. So in these kinds of patients, to increase compliance, I use spironolactone with loop diuretic. And again, as rightly pointed out by you, the cost is one of the important factor, because heart failure patient, they need to take this patient, medication for long, and it is very important. We don't want for minor side effect like gynecomastia, we don't want that patient should altogether drop an important drug like MRA. So at least means patient should continue these drugs, and if patient develops some side effect, then we can think of switching from one to two. Another thing is that it is said that there is no head-to-head comparison. Hyperkalemia will be more with spironolactone than eplerenone, but again that can be managed with slight dose adjustment. So my take on this will be, I will like to use spironolactone in all patients. Only in few patients where they develop side effect, I will go with eplerenone. Another subset of patient where I will use spironolactone only is a resistant hypertension patient, where eplerenone being not that potent will not be effective, but spironolactone being more potent will be more effective. Whenever in patients with resistant hypertension, I want to start MRA, I will start with spironolactone.
Especially in cases of resistant hypertension, we have seen if patient is on thiazide diuretic, and if we combine with MRA, the results are quite good.
Yes.
Yes.
So basically, MRAs are wonderful antihypertensive. It is in patients with uncontrolled hypertension. If you add a MRA, the hypertension gets controlled. It is very understated. It is not a diuretic. It is very understated antihypertensive. MRA should be considered in any patient with resistant hypertension whenever, in spite of your routine treatment, if patient's blood pressure remain uncontrolled.
Also, regarding eplerenone, it's a slightly shorter action X compared to spironolactone. That is one of the disadvantage for, because it has to be BD dosing as compared to spironolactone.
Yes.
So one of the reason for slight failure of that, more patient goes into failurability because of eplerenone OD dose. It is one of the problems.
Yes, sir.
I was reading somewhere. Yeah, I was reading the spironolactone is 40 times more potent than eplerenone.
Yes.
So this is a dose adjustment in case of if baseline GFR is more than 50 you start with spironolactone dose of 50 mg per day. If eGFR is between 30 to 50, then you should start with 25 mg alternate day. This is a basic dose adjustment with spironolactone. And for eplerenone, you should start with 50 mg per day, and in case the GFR is more than 50, and in between 30 to 50, you should start eplerenone 25 mg per day. So this is a dose adjustment which is required if there is a as per the GFR. And as per potassium level, if after starting of spironolactone, the potassium is less than 4, then you should increase it. Try to maximize the dose of spironolactone. And in case of if potassium is between 4 to 6, there is no, it is not 4 to 4.5.5. It is not, no adjustment is required. Between 5.5 to 5.9, you should try to reduce the dose, and above 6, you should start the MRA treatment and assess the potassium level frequently. So this is regarding the as per potassium and eGFR management, the dose of MRAs.
So if eGFR is about 30, so by other drugs, RD and the other beta blocker or ARBs, it improves the GFR. Then after 1 month, we can start the MRIs. This might be done.
Yes, sir. Yes, sir. Definitely.
The improvement in kidney function.
Function has improved. You can restart it. So every attempt should be there to introduce MRI in treatment of heart failure patient. There is no doubt about that. So this is what we have discussed, what is the preferred dose and how is the dose titration carried out in is there any difference from this routine recommendation in your routine practice?
No, sir.
So coming to MRA-related hyperkalemia, the fear which prevents us from using it in every patients of heart failure. As per this meta-analysis, the prevalence of hyperkalemia was 9.3, out of which 54% were truly. So only 50% of the patients with hyperkalemia were related to MRAs. Others were related to various other causes, and the incidence of hyperkalemia was less than 10%. So we should not we should not stop the MRA in our treatment only with the fear of hyperkalemia. That is the message. And it included large trial like FSS. So what percentage of heart failure on MRS development develop hyperkalemia, and do they require discontinuation of treatment? So it all depends on what level of hyperkalemia these patients develop, and almost it is less than 10% of these patients develop hyperkalemia, and routinely they don't require discontinuation. Only thing is that adjustment of dose is required. And how are these patients managed? We have discussed, I think we have discussed these things. So this is another important slide, timing of eplerenone initiation and outcome in patient with heart failure after acute MI complicated by left ventricular systolic dysfunction. Insight from FSS trial. FSS was the largest trial with eplerenone, which establishes the role of eplerenone in treatment with post-MI patient. The message here is that earlier the eplerenone administered, that is within 3 to 7 days post-MI, it improved outcome in patients with LV systolic dysfunction and heart failure. And this benefit was not observed when eplerenone was initiated after 7 days. So message here is that you should initiate the this eplerenone or spironolactone as early as possible in patients with post-MI management, patients with acute MI with heart failure or LV systolic dysfunction. And earlier administration improved the outcome by reducing the all-cause mortality as well as 34% reduction in sudden cardiac death in patients with heart failure post-acute MI. So the benefits, the message here is that earlier is always better than starting it after 7 days of post-MI patient. This also, I think we have discussed in clinical practice, how early as MRA is initiated for management of heart failure patient. Again, here consensus is that it should be started as early as possible in patients with heart failure. And this is a therapeutic algorithm in patients, management of patient with heart failure with reduced ejection fraction. This is what we were discussing. These are the basic pillars: ACE inhibitor or ARNI, beta blocker, MRA, and SGLT2 inhibitor. And then loop diuretic or fluid, when patients with heart failure comes with fluid retention, loop diuretic can be used. And if there is a, then you have to see if there is ejection fraction less than 35% or patient is ischemic, then you should consider ICD treatment in this patient. That is a class 1 recommendation. So patient should have ejection fraction less than 35% and QRS should be narrow. If QRS is more, then you should think of CRTD rather than ICD alone. So you should try to reduce the QRS by doing CRTD in these patients. And if patient's ejection fraction is more than 35% or device in these patient, device therapy will not be indicated. So if patient's ejection fraction is less than 35%, then you should see for QRS duration. If QRS is narrow, then you should think of ICD. Otherwise, you should think of CRTD. Or sometimes CRTP alone also. If after Holter testing, you feel that the patient's VPC burden is not there or patient is not having non-sustained VT, you can think of CRTP alone in these patients.
Sir, how much percentage of patients in your practice patient requires CRT or ICD in LVF patients?
So here there is a paradox. Many patients of our clinical practice, they need a CRT or CRTD, but affordability is the issue in our setting because these are the costly treatment and most of these treatments are not adequately covered by various TPAs, various insurers. So many of our indicated patients do not get this indicated treatment.
Do they do well later on, like after 5-10 years of first episode of failure?
Pardon?
Do they do well without the CRT or ICD, like, say in mortality benefit?
No, the mortality benefit is clearly there. At least the patient who has what I do in my practice, patient who has already had some episode of VT or documented non-sustained VT or high VPC load on Holter treatment, patients of heart failure, I will definitely recommend them this ICD. As far as CRT goes, CRT, if QRS duration is more and in spite of routine treatment, if patient continues to have recurrent heart failure admissions, then again, CRT is again should be considered in this patient. But most of these patients are not affordable. Means many only 10 to 20% of these indicated patients get this device therapy. But when patient has one episode of VT or one episode of non-sustained VT documented on Holter, they should definitely be offered this ICD treatment because that will be a life-saving in this patient. So at what stage of heart failure diuretic and MRAs both are needed? So answer is very evident. When patient is fluid overloaded, diuretics will be definitely loop diuretics will be required, and MRAs will be required in all stages of heart failure. There is no question. And what is preferred choice of therapy? Eplerenone plus torsemide, or spironolactone and spironolactone plus torsemide. So answer here is what we have discussed. Both treatment will be required for maintenance treatment of this patient. And the choice, again, as we have discussed, between eplerenone plus torsemide and spironolactone plus torsemide. So for all panel members, in your practice, any other indication apart from heart failure where MRAs are used?
Resistant hypertension.
We have already discussed that. Resistant
hypertension already we have discussed, and it is one of the most important indications for MRA.
So edema associated with hepatic cirrhosis, nephrotic syndrome. Yes. We use it usually in combination with loop diuretic. Then we use it in primary hyperaldosteronism tumors, aldosterone secreting tumor in pre-op. And if tumor is inoperable, we can use it for long duration in such cases.
Yes, so all indications of MRAs are covered now. What are the scientific initiatives? I think this is a question from CIPLA. They will discuss. So thank you very much. Any other comment from any of the panelists?
Sir, I want to ask you regarding prognostic investigations or scaling. Do you routinely do any scale in heart failure patient to tell them prognosis, year survival?
Routinely in our clinical practice, we don't do it. For prognosis, as far as prognosis is concerned, we do this NT-proBNP levels, and as far as on the basis of NT-proBNP levels, we do tell them prognosis. But as far as you are asking For cancer patient, we give 5-year survival.
Yes, sir. Yes, sir. Yes.
We don't, in our routine clinical practice, we don't talk of survival rate in patients with heart failure. No.
Okay. And sir, regarding CPET, do you routinely recommend CPET?
No, we don't. Again, we don't routinely use it.
Okay,
We
sir.
don't routinely recommend it.
Okay, sir. Thank you, sir.
Last is salt and water. Heart failure patient, diet control.
Yes,
Okay.
salt and water is what most important.
One thing I want to ask, many patients of this heart failure with the diabetics goes on recurrent hyponatremia. So how do you address that problem?
Pardon, sir?
Many patients of this heart failure with diabetics recurrently go into hyponatremia.
Yes, sir. Yes, sir.
So how do you manage those problems on OP basis? Or how do you manage the hyponatremia with recurrent?
So basically, sir, we have to adjust the dose of loop diuretics, and secondly, we can use drugs like tolvaptan in these cases.
What about using only MRA in patients of stable heart failure, not using loop diuretics?
Yes, definitely that should be a goal, but if patient is fluid neutral, if patient is not fluid overloaded, you can definitely think of using MRA alone in these patients. That's definitely, but what happens, these patients do develop symptoms if we stop loop diuretic. So mild means whatever lowest possible loop diuretic should be on board in patients with heart failure. So every attempt should be to increase MRA and reduce the loop diuretic in patients with heart failure. Because what happens if you try to increase the loop diuretic, the chances of hyperkalemia, chances of dehydration, all the chances of hyponatremia will go up with loop diuretics. And as such, we know that there is no mortality benefit from loop diuretic. So every attempt should be there to reduce the dose of loop diuretic in these patients.
A combination of loop diuretics with MRA is to be started initially rather than waiting for.
Yes, because symptomatic benefit patient will keep on the recurrent hospitalization will be low with if you use loop diuretic. If you altogether stop loop diuretic, the chances of these patients coming to you recurrently with heart failure symptoms will be more. But in a euvolemic patient or patient who has fluid depleted, you can definitely think of stopping these loop diuretic. So I think we can stop here. Any other comment from any of the panelists?
What do you think about fluid restriction in reduced ejection fraction patient?
Yes,
failure patient.
we should restrict the fluid as much as far as patient can tolerate, because giving diuretics and then asking the patient to take as much as fluid will not justify. So here you want to keep the patient euvolemic, that should be the goal. So fluid restriction is definitely indicated along with salt restriction. But this fluid restriction should not lead the patient to be dehydrated, so that in that case what happens, this chances of hyperkalemia increases. Patient do not tolerate the indicated therapy like ARNI ACE inhibitor. So whenever there is a ARNI and ACE inhibitor intolerance, you reduce the first step is not to reduce ACE inhibitor or ARNI. First step is to reduce the first step is to check the hydration status and reduce the loop diuretic. In spite of that, if patient do not tolerate or ACE inhibitor or ARNI, then you reduce the dose of ARNI or ACE inhibitor. So always you should maintain that balance of fluid status is one of the most important clinical assessment and judgment which you want to do in patients with heart failure. So over to you, CIPLA team.
Yeah, thank you so much, sir. I would like to really thank you, Dr. Pankaj, sir, for wonderfully moderating the today's session. I think, and particularly, I would like to really thank for conceptualizing this entire scientific program. And you have taken out the time for this, academic program, and shared your expertise with the panelists. So thank you so much. And equally, I would like to, thank you, the expert panelist also, for making this discussion, I think, more live and interactive rather than a monologue. I think it was a well discussion within the team. And we at CIPLA has, felt that because most of the time, sir, what is happening, like into the market, a lot of meetings are happening on SGLT2 and ARNI also, because these are the strong pillars for the management of heart failure. Somewhere we felt that MRA is somewhere being neglected, and we being a strong into this therapy, so we have taken the initiative and onus just to conceptualize this kind of academic program, so that more and more usage of MRA can be disseminated within the physician unit, so that patient can be benefited as the indication is their class 1. So this was the thing, and we have got a lot of insight from this today's discussion. So thank you, all of you, and thank you, Dr. Pankaj, for making it happen for the today's scientific discussion. Thank you so much, sir.
Thank you very much. Good night, all of you.
Thank you, sir. Thank you.
Thank
Good
you.
Good night.
Good night.
Right.